Welcome to the webinar In-Depth Surgical and Restorative Guidance for Full Arch Rehabilitation. This lecture will be presented by Jeff Carlson, CDT, and we will begin shortly. And with that, it is my honor to welcome back in September, Jeff Carlson, CDT, our Senior Implant Specialist. Jeff has more than 40 years of dental experience with almost 30 years focused on dental implants. Jeff is the primary author of a 300-page, fully illustrated cookbook created for restorative dentists, and he is the co-author of a corresponding auxiliary manual. Jeff co-developed a restorative-based training program that more than 9,000 dental professionals have attended nationally and internationally. As senior implant specialist for NDS in Sequence, Jeff provides technical chairside support and lectures across the country on immediate loading full arch restorations in sequence guided prosthetics and the latest advancements in implant technology. And with that, it is my honor to say, take it away, Jeff.
Do we still have some time left?
Yes,
Thank you,
we do.
Jessica. Hey, everybody, welcome. So thankful that you took some time this evening. I'm really excited about this. This is my first time presenting all this information combined together. Hopefully I won't get off track. I've really put a lot into this presentation with the most current data that we find sharing with our clinicians when it comes to the full arch, really with a very big emphasis on the digital workflows. We know that's really the direction where everyone wants to go. We still need to understand about analog workflows, and I'm not going to dwell a lot on that this evening, but know that there's still some of the workflows today aren't quite there yet. A lot of them are, but analog is a nice backup to have. We like to call it cross validation. So as I'm thinking about this right now, I'll just say it that if you are collecting records for a case, and if you're not sure if maybe something that you've done digitally is good enough, do go ahead and like do some impressions, PVS impressions, things like that. Just to back up again for cross validation, we want to make sure that we're giving your patients the best possible outcome that we can. So, without any further ado, I'm going to be touching on pre-surgical planning and communication and talk a lot about day of surgery, and then provisional options, different protocols that we have for provisionals, and then a little bit on the delivery of the definitive. What's I do need to, since this is a CE program, that just a couple of quick slides, disclosure slides. I am an employee of NDX and Sequence, and any financial support that I'm receiving is from National Dentex for this program. So we know now that pretty much all the major implant companies are all promoting or involved in the full arch reconstruction. Many of them have some of their own, not just software, but they're actually fabricating guides and things like that. So there's a lot of people out there that are available to support you in your endeavor. If you're in the beginning of your learning process, there's a lot of implant manufacturers that have some very talented, knowledgeable reps that aren't just salespeople that really know their ins and outs of the clinical world with these full arch, and as well as laboratories. And so tonight, I really want to focus on really helping you to get a good flavor and an idea of what's available, what might make sense for you to incorporate into your practice. So one of the things you're going to find is you have a lot of decisions to make. And we are here to help you with those decisions. But when we think about, let's just kind of divide things up here. So surgery. There's a lot of things to think about nowadays with surgery. Are we looking at free-handed surgery? Do you want to do guided surgery, fully guided surgery? And what does that mean? Using precision IOS technologies, how are our intraoral scanners playing a role? Where do they fit in? Photogrammetry is that photogrammetry something that you want to embrace and bring into your practice? We'll touch a bit about some of that, show you what that's providing for you. And then also some other alternatives, a fully guided, what I'm referring to as a modified alternative to fully guided. And what does that mean? So that's kind of the good news, really, is that you have decisions, you have options. You're not so pigeonholed into some particular way of doing things. I like to say that pretty much, you really experienced laboratories today that are involved in this full arch digital workflow. They can meet you wherever you are at with your workflow and either complement what you're doing or help create a workflow that's specific for your needs and for your patient's need. So restoratively, it's a little bit, that was kind of strange. I always thought, surgery has always seemed to be the simpler part of things, meaning to understand it, communicate it, not necessarily to do because I'm not a clinician, but restorative is really because of this digital workflow. Quite honestly, restorative has become a little more simplified, really. We still need to have a lot of understanding about occlusion, biomechanics, and things like that. AI is helping. It's not a replacement for, I like to always say it's artificial intelligence is exactly what it is. So it's a nice aid. I think we're going to see more of it being incorporated into things, even by the end of this year and next year, of course. But as far as restorative, what is fully guided restorative? And then again, where does the precision intraoral scanning play a role in the restorative process of these full arch cases? And also analog, or a conventional way of doing things. Where does that play a role? Does it play a role? So we're going to cover all these topics this evening. So hang in there with me for the next couple of hours, and I'll try to keep you interested in these topics. So we're gonna start talking about surgery, and I'm gonna take each one of these topics and just kind of give a cursory overview and then a little more dive into it. I find that that's how I digest information better, is more like that, the elephant, how do you eat an elephant? It's, so massive you can't do it. A bunch of little elephant burgers. So let's have some elephant burgers here. And so we're going to start with our surgery and just look at a review, very quickly, review of freehand, what that really means when people say, I want to do freehanded surgery. So basically, we're talking about, without a lab or an in-office fabricated surgical guide, but however, possibly a guide just to show the position of where the teeth are going to be, as you see on the bottom left here, figure A. This is very common. It's like basically just a troughed out denture. Very easy to fabricate, very inexpensive to fabricate. For you doing freehanded, you're taking on the role of about bone quality, available bone, angulation of the implants to pardon me, to capture the best bone possible, to avoid certain anatomy, etc. But it's still nice to have something here that you can utilize, as you see, that says to you as the implanting clinician, teeth are going here. And so that trough is kind of a way of saying, doctor, if I was the laboratory making you this particular guide, I would say, doctor, here's a trough over the alveolar ridge. It's all you. You go wherever you want there, but know that for the patient's smile, what they're coming to you for is their smile. This is where we're going to put the teeth. So that way you have an idea where your angulation, and things like that to help you. The other thing, when it's free-handed, you can use different types of little guide pins, parallel pins. Some clinicians that you see to the far right, it's just a matter of leaving some teeth in place, utilizing a long axis of a tooth to help you, assuming the tooth is in the right clinical access, for lack of a better term. So free-handed is really taking on a lot of responsibility. It is a more or less expensive way to go with it. I think that you're going to find, for those of you that are maybe newer to the full arch, that a guided system is going to be, I think, something that you'll want to be at least go with guided. And so when we say guided surgery, what we're really referring to is that, as you see here on the bottom left, this is a surgical guide that's more of a tissue supported. So this would be utilized in a flapless surgery where maybe the patient's edentulous. You know exactly where the bone is, you know where the sinus or the nerves are. You're you're just going to do flapless. You get plenty of bone, and the center guide is this one is a tooth supported, where you'll extract those remaining teeth after you get some of the implants placed. But really, what guided surgery is going to do for you as a clinician, it's going to help you to help dictate the depth control and the rotational position of your implants, the timing of the implant. Those are the two key factors when it comes to the implant placement, beyond, of course, having it into the proper position within the alveolar ridge, avoiding the sinuses, the nerve, staying your 2 millimeters here and there from that, keeping 3 millimeters between the implants, all the things that you've learned through your training. Um, so these surgical guides, which you see on the right, most all surgical guides now, they'll have some indication here, this blue line, for this particular type of a placement mount that you see here. The has a hex, and that represents the internal hex of the implant. And this implant is depth controlled because the placement mount is wider than the sleeve of the surgical guide. So that's going to be your vertical stop, your depth control. As far as rotation, then, as you get close to the depth, you're going to slow down, and you want to, for this particular type of a placement mount. Some will have dots, some might have lines, but you want to be right in the center of this flat, of this, which would represent a hex inside the implant. So this blue line, this would give you the position so that if you're using an angle correcting multi-unit abutment and you wanted to bring, say you wanted to bring the alignment of the abutment palatally so that you're not infringing on the for anterior aesthetics, you want to make sure you get your implant in the right position. If you're off a hex or half a hex, an angled abutment may not give you the right positioning. So I know that might be very fundamental for some of you, and I apologize for that. Hang with me. We're going to have some pretty good advanced stuff as well. But in all fairness to those that are trying to figure out how to, learning the process, I want to, kind of give you some fundamentals along the way. Staying on that concept of our surgical review, so fully guided. So we just looked at guided. So fully guided is where you're going to have the bone reduction would be guided. The placement of the implant, I mean, the creation of the osteotomies would be guided. The placement of the implants are guided. Even the placement of the multi-unit abutments will be guided. And fully guided, we're really talking about actually the prosthesis, your provisional, is guided into position at the day of surgery for positioning it. So that's really what fully guided is, where it really helps to I can't say it helps to minimize variables. Nothing is ever going to eliminate variables. If someone tells you they have a system that eliminates variables, I would probably say walk away or sit around, listen to them, see what they have to say. But the best we can really do is to help minimize variables. And by doing that, we're helping to minimize surprises. And as we all know that have been doing this for a while, there's really not too many good surprises in implant dentistry. So how do you choose? We just threw a whole lot at you. And so now, now it gets to the point of how are we going to choose? What's your reference points? You're going to look at what's my surgical experience. You want to look at the patient's physiology, look at bone quality, their ability to open. Are you going to be using, are they going to be sedated, IV sedated, is it gonna local sedation, oral sedation? Those are things got to be taken into consideration. Are you going to incorporate some of our new technologies, photogrammetry, the iOS? Um, how many appointments are going to be involved? Do you have a laboratory locally to support you? Are they versed in these technologies? So these are all things that you should be on your checklist. I kind of like to think of it as like a pilot checklist, that you're just going to go through. Yep, got it, got it, got it. Oh, I don't have that. Well, then stop for a moment. Do you need that? And if you do, this is all kind of pre-surgical planning. So it's not the patient in the chair you're making these decisions. You've done this ahead of time. So I want to help you with these decisions. Uh, and I always feel like the best I can do is to give you information so you can make your own informed decision. Um, and I think that's best that you're making your decisions as long as you have reference points to base those decisions from. So we're going to go a little bit deeper dive now into the clinical and technical options that you have with many of these things I just kind of threw at you right away. So let's take a little bit look about photogrammetry. And I got to be honest with you, a year ago, I didn't realize this, but photogrammetry uh, is really it's technology that utilizes special scanning units and scanning indicators that to provide a near perfect 3D registration of the implant and MUA positions to one another. That's very key here. Photogrammetry is giving you the most precise possible way you can that we have available in dentistry today to identify the position of the implant with the MUA on it, but it relates it to one another in the arch. It does not relate it to the teeth, to the alveolar ridge. So there's limitations there when it comes to what we need to do for full arch reconstruction. So it does not capture the required data of the working arch dentition or the tissue, the opposing arch dentition or the tissue as well, or the bite. So that data, you do need to utilize an intraoral scanning device for that. There now, photogrammetry, there's more advances even this year. They're coming out where some of the devices can do a little bit of both. So it's important that because technology is emerging and changing, that you stay current on that. So some of the things I may say, in 2, 3 months from now may not be valid. So good news, bad news, right? Along the lines I was just saying that we have seen changes and that we're able to accept some different protocols that maybe we didn't think were um, acceptable 6 months ago or a year ago. And like I said, the photogrammetry is the most accurate way of doing it. Um, you need to go ahead, I think, and make your decisions about do you need to embrace this technology into your practice? Is it right for you? And come to your own conclusions. I do believe this wholeheartedly that the labs that are really doing this on a daily basis, they can meet you wherever you're at, whatever skill level you're at, whatever workflow you're at, to really help you to make sure that you're working with the best workflow for your practice and for your patients. So let's just take a look. There's more units than this out there. These are some of the, I think maybe more popular is a way to say it. The iMetric iCam 4D camera, a very nice system. The PIC system, again, a very nice system. One that really probably around longer than most any of them that have been around. And I'm not going to go into a lot of details on any one of these systems. That's really not the intent here. You all can go out and reach out to the manufacturers. They'll set up meetings with you, whether it's online or maybe they have reps available in your area to come out and do some demos. Um, and then the Micron Mapper, another good unit. We get good results. We get good results with all these units. So these are some things that we're utilizing, we're receiving these data on a daily basis from our clinicians around the country. So these are really good, reliable systems. Now, precision iOS, um, some of people have used the terminology gammetry with respect to that phrase is a trademark phrase. So we use the phrase precision iOS, precision intraoral scanning. And really, this is something where really what that is that you have scan bodies that have been designed, very precisely designed, and a little different than your single unit scan bodies for crown and bridge cases, because it's not recommended at all to use a single tooth or a crown and bridge type of scan body when you're getting into the multi units for a full arch case to capture all your data. So there are specific brands and designs for these precision scanning indicators, as I like to refer to them. Um, iOS scans are required to capture these opposing information, opposing dentition, the bite, and of course the opposing arch and working arch mucosa. We utilize within National Dentex a terminology that's been trademarked, simply iOS. So it's the same kind of concept. We're just talking about using precision scanning indicators. So whether you're on our website or you're getting some literature, or maybe you're talking to some of our technicians or someone, if you hear the phrase simply iOS, that's what we're referring to, is that precision iOS, or using an intraoral scanner with specifically fabricated scan bodies for full arch reconstruction. I hope that kind of cleared some things up. So once again, that is our terminology that we've come up with. So here's a look at some that, and again, there's more than this. These are ones that we have good relationships with these companies, good results with them as well. The one on the left, Truss, is another very nice system. I'm going to show you a little bit more on a couple of these systems because I need to show you some of the technology, and I've documented cases using these technologies. OptaSplint by Dental Arches, very well sophisticated system. Like that a lot as well. Implant Direct, their direct scan, a nice system. Again, I just encourage you to go, reach out to these people, make your own decisions, hear what they have to say, talk to other people, talk to your colleagues about it. There's a lot of choices to be made out there, decisions to be made out there. Again, you're going to need something like this if you're using photogrammetry still, but there's a couple of units now, I believe one for sure, maybe two, that you don't necessarily have to have an iOS scanning unit if you have that particular photogrammetry unit. But I'm not familiar enough to discuss it, so I'll let you research that out on your own. Um, Still talking about the fully guided surgery. When we talk about fully guided, it's not only about the guided bone reduction and implant placement, but it's about guided prosthetic steps. And we're going to get more into that, where you're actually being able to get your MUAs guided, um, as we mentioned, the provisional as well. The terminology that trademark that National Dentex has is fully guided prosthetics. If you see that in literature on the website, even though the word prosthetics is in there, this is really talking about the full from surgery all the way through provisional on the day of surgery. And we're going to show all that in our presentation this evening. A lot of these technologies going all the way through the complete case for you. This technology, the fully guided, um, can utilize both digital and analog or a combination thereof. It can be solely digital, solely analog, or like I say, combination thereof. So getting a little review now of the fully guided, um, what you're seeing here, there's a lot of components with these type of systems. You're going to have beyond the planning that's, from all the planning, from your CT scan, from your online meetings, talking about where the implants are going to go, where the anchor pins, the horizontal anchor pins are going to go, all these different things. Um, these are a series of different guides. I'm not going to go through all of them. That's not the intent tonight. Uh, you have bone foundation guides, guides that help you place the implants, provisional prosthesis that are prefabricated already. So, and even sometimes, at least with some systems, ours included, the components, the abutments have already been prepped if they need be, pre-selected, etc. Um, again, uh, that's the fully guided system. Now, also available, and I don't have a better term for this. Another, I just came up with this really a couple of days ago. I hope this is okay with my company, but I'm referring to it as modified alternative, the fully guide. Again, trying to be generic in our webinars. We don't want to be all commercial, but we do call our Simply Guide Plus. And where this is really doing is it's similar to what you saw, but it's a lot less components. Obviously, there's costs are different with that, but also what you get from it will be a lot less than that. But those are things that you get with it. And I think what I see a lot of clinicians really looking for, quite honestly, especially our more experienced implanting clinicians, and our specialists, really our oral surgery friends and perio friends that have a restorative referral base. This is a nice alternative to look into because it's giving you what's very important is to get guided bone reduction. That's still as skilled as many of you are with with your surgical skills, knowing how much bone reduction, kind of freehanding it, eyeballing it, so to speak, can still be a challenge. So having really precise bone reduction is a real benefit to your restorative doctor because that makes sure the laboratory is getting the adequate amount of intra-arch space for whatever type of prosthesis that your restorative doctor is looking for the patient. We know that say your denture teeth in acrylic with a titanium bar requires more inner arch restorative space than say a zirconia full arch. So if you didn't have enough restorative space, and the lab breaks the news to your restorative doctor that, hey, we don't have enough room to do this denture teeth and hybrid, we call it DTA with a bar, denture teeth acrylic with a bar. We don't have room for that. It doesn't mean we can't restore the patient, but you're going to need to go to probably a zirconia, and it's going to cost more. So those are things that, these shouldn't be surprises, especially doing you have the opportunity to have all this guided between all the scans. You can see a lot of different more information I'm going to share with you today. We really should be able to help minimize a lot of the surprises beyond minimizing variables, if you will. So what this does, it gives you guided bone reduction and then the guided implant placement. So depth control, rotational control. So this clinical photo on the bottom right, that's what you're going to get from something like this, where you still freehand in the multi-unit abutments on. You still got to figure out which rotational position of a hex, 6 different positions at 60 degrees each position. Only one's going to be the best position. You still got to work that out. But this is being done where you still get some real key components. So this is what I just termed as a modified alternative to fully guided. So I'll probably get some feedback tomorrow on that one. Um, so other decisions you will need to make is about the provisional. How, when, and who will be delivering the provisional. That's kind of the neat thing, quite honestly, about this. And I think for our specialist friends, this has really been a game changer, the digital workflow for you. Um, our oral surgeon or a periodontist, many times you'll have the restorative doctor come to your practice to do the pickup or the conversion of the case so the patient can leave with a provisional or have a technician there. But if you have another clinician come, your referral clinician come, well, they have to leave their practice to do that. You have a chair tied up doing that. But you're going to see that this gives you an opportunity where you don't have to do anything prosthetically that day, quite frankly, more than put a multi-unit abutment on. And I'm going to show you all that. But that's what's kind of, to me, is the exciting part of this, is it gives us more options. And yeah, it's more to think about. But once you get one that works for you, I think you're really going to really be able to embrace this more confidently and competently to provide your patients with this treatment modality that they so many of them want and deserve to have. So the key here, when you're going to get into these same day delivery of a provisional, when I mean same day, the same day of surgery, whether you're delivering a provisional the same day or you're going to have a provisional the next day. So when it comes to digital workflow, you can have a next day provisional or you can have a same day design. So I'll make sure you're seeing that word design there. And I'm going to explain all this to you. But a key to this, the reason I have this required here is that whether it's working with any of our laboratories that are specialized in this, or with some of our other, good laboratories out there, um, that are, you need to talk to them ahead of time. There needs to be planning. You can't just have a patient scheduled tomorrow. What do you need from me? It's not going to work. So I think a good guideline is just plan yourself, say 2 weeks. Not all labs need 2 weeks to do this. I'm not even saying we need 2 weeks. I'm trying to set a criteria so that you're in a comfort zone in your learning stage, maybe with this. But talk with your lab. Say, what is your turn? What is your time? Is it 10 working days? Is it 7? What do you need to, for me? What do you need from me technically, clinically, records, and when do you need it by, so that we can do what I'm about to share with you? So I can tell you this is what pretty much all the labs are going to need prior to your surgery date to provide you with either what they do is they pre-design your provisional, and they wait for the day of surgery to get the scans of it. Once your iOS scans, your photogrammetry scans, the day of surgery, you're going to upload those to them that same day, and then they're going to start putting things together and either do a design and shoot that to you in about 2 hour time period, and you can print that in your office if you have your own in-office printer, or they can print it at the lab, stain and glaze it, and then get it out to FedEx yet that day, or UPS, and the next morning your restorative doctor or whoever's going to be delivering that to the patient the next morning are delivering the provisional. You're going to need to have preliminary scans of the working arch, the opposing arch, and a scan of the bite. That's it. That's three of the minimal things. It's nice to get photos and other things, but I'm just saying, you've got to do this. I want to share this with you too, that many of these patients that are going through this type of treatment, they have they're not, I want to say they're not good dental patients. I don't mean that as they're not nice people. Um, their dentition, they're doing this for a reason. They're a terminal dentition. It's on its way out. They've had either broke down dentistry, poor dentistry, whether it was, for whatever reason. And a lot of these patients have a closed or collapsed vertical, and that needs to be addressed, because we don't want to use your provisional to open a patient's vertical, 4 or 5 millimeters on the day of surgery, because they've lost their proprioception by edentulating the patient, that they're not going to, and you need to deprogram and reprogram the musculature. Otherwise, they're going to try to keep closing to that vertical that you've opened them, but that's not their functional vertical dimension of occlusion, that's been habitual, that their muscles have been programmed to. So there's a time period that you need to deprogram and reprogram the musculature, so that the patient, when you are putting provisionals, that it's more in harmony with the entire musculature, the masticatory system. And that's where people make a mistake, is they don't think about that, and they just come in, and a lab can do a great job making you guides and, great provisionals, and do a great job the day of surgery. But I tell you what, in a couple of days, that patient's going crazy because they're just not ready. They can't, they feel like they're too open. And you start pounding on these freshly placed implants, for lack of a better term. So my point here, sorry, I got long-winded on that topic. But if you're going to open the patient's vertical, do that preliminary. Make sure they can tolerate the vertical you're wanting to get them to. But when you do your scan them at your desired vertical. That way, the laboratory can do the provisionals at that vertical, because the arc of closure changes, of course, as you change your vertical, and that may also change the plane of occlusion when the laboratory is designing your prosthesis. So this is something where people get into trouble. They don't do what you're seeing here in the bottom right, and they're overcompensating, and then it's just they're fighting it. They're doing a lot of occlusal adjustments, a lot of patient discomfort, and you're putting these implants at high risk of early failure. We do have a nice little checklist available for you that kind of just walks you through some of the timelines, like what to do 2 weeks prior, 1 week prior, day of surgery, um, so that you're not surprised with any of this. And I cannot stress enough, my friends, that talk to your lab ahead of time, get a good dialogue with them. And I've been in dentistry, as Jessica mentioned, a long time. I think I'm coming up to 46 years. Hard to believe. And communication has always been important. I've never seen the need for a level of communication as there is when we're doing full arch, full mouth reconstruction. And so, talk ahead of time. It still shocks me and disappoints me when I get calls from doctors that are saying, "Thank you." I'm getting some of the thumbs coming through or clapping. Um, Got to have that communication. These things that they say, calling the night before, saying, "Well, I don't have this or I don't have that." Your patients deserve better than that. They just do. They're paying good money, have high expectations. This is life changing for them. Do the same thing for them. So there, I got off my high horse on that one. Even if I was in person with you all, I'd be pointing fingers and walking up and down the aisle with you. So let's give you a little overview now of photogrammetry. So cool. This technology is so exciting to be in dentistry. It really, and I'm very fortunate, I think, to have such great people around me that can teach me a lot of things. Um, I'm gonna give a shout out to Tremaine Watkins, is our digital expertise, and I've learned a lot from him. And I thank him for the time he shared with me, even helped putting this presentation together. So day of surgery, your digital camera, scanner, interchangeable words. You can do your surgeries either free-handed or guided. Getting the implant into the bone, that's however you want to do it. That's the beautiful thing about it. No one's dictating to you, doctor, how to do your surgeries. Do whatever you want. We'll meet you. Technology will meet you where you're at. So what you're seeing on the right, this is the micron mapper, and on the right are their scan bodies, scan flags, a lot of different names for these. You see little dots on them. This is your GPS system. And you're going to see, I'm going to show you a couple other, briefly kind of show you like PIC has dominoes, um, and ICAM has kind of like cube dominoes, but it's all these dots all mean something, and that's what these scans are picking up. What's crazy is this scan here, it's a 10-second, 15-second scan. Um, and most all of your scanning is very, very quick compared to iOS scanning. So what's happening is, so when you're scanning, that the screen on the image on the right is the laptop, it's actually behind the doctor here. And so I took a picture of that separately. So in real time on the software, so those scan bodies here are showing up on the computer, so you can see them start to appear. And then the software is going to, some of the different software, different systems are turned different colors. What's really cool is like ICAM will go from red to green. When everything's green, then you've captured all the detail. So it's really fun. It's fun using this technology. It's really quite amazing. So in real time, you're getting this data, and then that's the information that you're going to send to the laboratory. Right from there, you just click the lab's already been, you've communicated the lab ahead of time. They know these scans are coming. So if they're going to do a design for you, it's all set up. And as soon as that hits their computer, the software, there's then the designer at the laboratory is putting together the scans that you took a couple of weeks prior, merging that together, either again to give you a design you can print in your office that same day, or next day delivery, which we're seeing a very popular way to go. Patients just want to go home, go to bed. They're not going anywhere. And it makes it makes it a much shorter procedure for them, especially if you're doing IV sedation. I've been doing more cases, it seems like, than I have in a long time, in hospital situations in the OR, where we're really conscientious about being very effective with our time there for the patient's safety, quite honestly. Um, so let's talk a little bit about precision iOS now on the day of surgery. Um, Again, here some important considerations that you want to talk to your laboratory, let them know what system you're going to be working with. The ones I just kind of showed you, whether you're working with truss, implant, with a direct scan, um, OptiSplint, some of the other ones that are out there. I mean, just because I'm not listing them doesn't mean they're not good. It's just the one that we've kind of embraced early on and been working with. Um, but you want to let the lab know I'm working with this. Is this, and even do some trial runs, maybe uploading some files or things. Don't wait to the day of surgery to start figuring out if your computer talks to the lab's computer. You're going to need something that we're referring to as reference screws or fiducial markers. I'm going to show you more of those. Um, and if you're doing, freehand, you're going to need, and if you've not done it before, you're going to need extra inventory of abutments and implants because you're not as tuned dialed into what you're going to need when you do it when you have more of the guides and more information from some of the CT scans. So let's take a look at some of these precision iOS systems in a little bit more detail. So again, I kind of showed you this image here. So like terminology, scan body, scan jig, scan flags, um, they're all going to have their own names, but they're all kind of referring to the same. And you're going to see that they function quite similar. Um, and yes, there's some nuances of one that has a features that are the benefits are greater with this one. Uh, you just need to again decide what works best for you, what's your best price point, what best support you get from the company. That is with anything, just like a good implant, a lot of good implant companies out there. You really rely on the rep, that rep can really make a big difference. The same with these companies, having good technical support, customer service support. Again, that's another extension of your practice that provide your patients. So some of the things that you need um, and so we'll talk about these reference screws or fiducial markers. These are nice ones. These I'm showing these are from Digital Arches. They're called their Arch Tracer. They're again the design. It's the geometry that's here that's designed that their scanners are picking up, and these need to be placed uh, uh, prior to surgery. Of course, you numb the patient up, but before you make any incisions, these markers need to be placed and they're not removed until afterwards. And you do your first scan with these markers in place. Um, and sorry, I just had a duplicate slide there. Um, you need a drill that, there's a corresponding drill, usually, not always. And then there's a driver here for this as well that fits over this for driving that. Again, different systems you get, they'll have maybe different ways of doing it, but that's pretty simple tooling for this. Um, so again, what you're going to do, the first part of the surgery after you anesthetize the patient, you're going to place. We want to see a minimum of two. So maxillary arch, we're looking to see two in the palate. You need to make sure if you're using guided surgery, make sure if you're using like a bone foundation guide or some type of guide, reference guide, where they're going to be placed. Make sure that your reference markers or your fiducial markers are not going to interfere with the componentry that have been fabricated by the laboratories or your flap, bone reduction, etc. We like to see two, spread them apart. I like to see maybe about 8 to 10 millimeters space. Again, your scanner's got it. We want to capture the distal side of these as well. The more information you can capture, it's like getting a margin on your impression. You get a very accurate impression of your crown prep margin. You're going to have the lab can make you a beautiful fitting crown. Same here. You get a good accurate scan of these reference marks of all the scan bodies, these markers. It gives them a clear vision in the 3D world, which is still 2D because it's a flat screen, but they're going to line up the references and between AI doing some of the lining, the technician doing the lining, but they need to see this information. So here you see that on the right side, the one each in the retromolar pad area. The bonus one, the third one, it's optional, but I tell you, just the more you give the lab, the better. This is one in the anterior, okay? It doesn't take very long to put these in at all. Patients, I mean, they're easy to remove as well, but they're done prior to the surgery, and then you scan that. That's your first scan the day of surgery, are these markers, okay? So now you've got the scan done. Then the other thing you're going to do, again, this is like at the patient in the chair. You've numbed them. You've placed your reference screws. You scan those. You're going to scan the opposing arch. You're going to go ahead and scan the bite. Then you're going to go ahead and reflect the tissue, whatever protocol you're going to be utilizing. You're going to go ahead and place your implants, freehand, guided, again, whatever you want to do. Then you also need to place the multi-unit abutments. So you're always scanning the multi-unit from the multi-unit abutment. You're going to see, I'm going to show you that we really like to have a scan of the top of the exposed MUA, and then also a scan of the scan bodies that we're going to show you all that too as well here. So the multi-unit abutments will be placed. All right, so now we're getting to have some fun. Now we're going to go ahead and utilize whatever system that you've elected. I happen to show a slide here using the OptiSplint system. So here the implants have been placed, the multi-unit abutments have been placed. So prior to suturing, the protocol with this system, place the, and you're going to see also that sometimes laboratories will modify some of the protocol that the manufacturers may say. You just, people find different ways of things that work best for them. So, if I have some of our friends that are from our manufacturers that are watching, say, well, we'd like to do it this way or that way. Um, you know, I always think it's best to follow what, whoever you're working with, what they can say, yeah, this is what's working for us and how we're doing it. Um, so we like to see this. You can see, make sure everything's seated, and then scan these MUAs. And when you do this scan, you also want to, so now we're scanning this. You want to make sure that you're capturing the key components of these of the scan body for this particular system. This is the key part where that geometry is what the software is looking to capture. This is just under, these um, are retention areas where you're going to see the mesh there's a framework that can be put on and luted together. But what you're trying to scan that you're capturing is this portion of that scan body. And then of course you want to, I got a little yellow circle here. You want to capture that scan marker. So when we're scanning, always capture these all the reference marker, the reference screws, the fiducial markers, always capture those in the scans. Just that's what you need to do to make sure we're able to do it, do the best job for you. So I'm going to kind of do a little side-by-side comparison just to kind of show you that you're kind of doing the same thing with the different systems. They just have different configurations and different concepts of doing it. So with truss, again, here's their scan body, their scan jig, and then a scanning of it, and then they glue them together with some material. This is kind of part one of that. And then here's your OptiSplint. You're gonna line their scan bodies up here. They have a couple different sizes of this little honeycomb framework. And that will be then luted to these frames to give you like a verification jig. And then, so that's what you're seeing here. Then with with any system that you're luting together, when it comes out of the mouth, you want to reinforce that, for shipping purposes, and just don't want anything to move. Very important. Nothing moves here, right? Truss has analogs that come out in their kit, and they actually provide a little denture box, pre-mixed measure of powder of lapstone, and a little measuring vial for water, and you can mix it up and you pour a little. Some of this is optional to pour a little master cast for that. Again, look at these different systems and find out what works for you, what you like. Similar with so OptiSplint, when that comes off, they also have some analogs that can attach, and you can pour models as well. So there's just a very nice workflow that you can create with these. They're just really give you good information. So now that you've done your scans, those scans, we're not done scanning yet. Now what we want to do is have you close the flap, and do that around the healing caps, the multi-unit abutment healing caps. Now, I'm going to show you a couple different things because some of the systems have a healing cap that has a twofold purpose where it can be act as a healing cap for suture around as well as scanning. But the point I want to really make here right now is that there are a lot of different healing caps. And if you just put a healing cap in and was to scan that and don't communicate to the lab, they need to know the brand, they need to know the size. And by the way, not all these, not all, I'm not talking about the ones in this image here, but not all healing caps have geometry that when it's scanned has any meaning to the designers at the laboratory when they're trying to line your scans up. So always even talk to the laboratory about healing caps and the multi abutments. What should you have? What do you need to order? Um, so this should not be a surprise for you all. You've got to talk to your laboratories ahead of time. So now you've sutured around nicely, as you see top right here. You got everything closed up. Those are healing caps. What we really recommend doing, and this we're going to ask you to do this, working with us, is we're going to remove the healing caps here, and we want to see you do a scan of the healing caps and capture, if capture the reference screws. You're going to see this again when it gets to phase two, so I'll talk more about that. But then this is what we're getting at the laboratory. This is the digital image the lab gets. So now the lab has all that to start lining these scans up. Once again, folks, we're day of surgery. So this has all happened a day of surgery. So there's a lot of scanning going on. And make sure you know how to scan before you do your first case. Practice on models or whatever, practice on your assistants, on each other, what have you. So as I was alluding to in the other slide, here, this is an off the splint system here where they have a scan cap that can be, use that for suturing, and that scan cap actually is designed to the geometry here matches that geometry of that scan body like that. So just to kind of let you know, and other companies may have similar things like that. So once again, it's very important when you are doing those scans as you are capturing those reference screws. And I keep saying this because I cannot tell you how many times that uh, we get scans in and we don't have enough information. And boy, we hate breaking that news to you all when you've done such a great job and the patients were, went through what they went through, and then we don't have some of the data that we need. So that completes the surgical steps. At this point, you could dismiss the patient if you would choose to do that. So now the next step is to upload this data to your laboratory. And so these are all the scans that you're going to be uploading to the laboratory that you took. Again, this is day of surgery. So you see that you've connected to the laboratory. You're going to upload the pre-op model with these reference screws in. Then you're going to see the iOS scans, the scan of the exposed multi-unit abutments, the working arch, the bite, and then you're going to fill out the prescription, and you want to send the prescription as well into the laboratory with that. And most labs have like online prescriptions with nice, easy drop down boxes to fill in to give them the information that they need for this. So now you've got the information to the lab, and let's assume that you did get all the preliminary scans in the lab, and now you've sent in to the laboratory your scans. Now, labs are going to have a cutoff time on the day of surgery for them to either A, provide you with a design the same day so that you can print it in your office, stain and glaze it, and deliver it to the patient the same day, or they can print it at the laboratory, stain and glaze it, and get it in FedEx, overnight it, and it arrives the next morning to whoever wants to seat the provisional the next day for the patient. And to my oral surgery and my perio friends, this is where we see a really good practice builder when doing these type of cases where, patient leaves with just healing caps on the MUAs. They're not going to be chewing anything anyways. So 8, 9 o'clock the next morning, or based on where your doctor's located, maybe 10:30 in the morning, the patient shows up in your restorative doctor. All they need to do is unscrew a healing cap and screw in the bridge. Now, most of them are not going to have any metal copings in them, They're going to utilize screws, and again, talk to the laboratory about this. Make sure you have the proper drivers. They may utilize what's called a power ball screw or a desk screw. Um, there's a Rosen screw. There's some different screws that um, allow to get a really good seat, accurate seat from these scans. So again, there's some special armamentarium that's needed here, and you don't want to be caught without that when the time comes. So communicate. Did I mention communication yet with your laboratory about these things? But I got to tell you, it's amazing how good they fit and the occlusion. We hear it all the time. Bites were just spot on. I mean, this is some. I just think this is really some great technology. I mean, some of you been. I've been with some of you. Maybe, hopefully, some of you on the call have been with me in surgeries, and I know we've been sometimes challenged at getting all the bites right and things like that. But it's pretty cool. Now, if you don't meet the cutoff time with the laboratory, um, you would either get the scan the next day, or maybe you can't deliver it the next day. Maybe you can print it. Maybe you're working out in the evening, staying late doing it yourself, doctor, and then have the patient come the next morning. But either way, that or that provisional could arrive 2 days later. So things to talk about, things to be aware of. So I want to focus a little bit here now on what are you what are you getting? If I keep hearing a lot of doctors, they want to do in-office print. I want to do my in-office printing. Talk to people that are doing it and have done it. I really encourage you to do that. There's a lot more to it than I think than what you may initially believe if you haven't had a colleague that's doing this. Maybe go to their office, watch what it takes. You're probably going to have an assistant do a lot of this, and usually that's going to be probably your most skilled assistant, and they're going to try to fit this into their busy day. I'm not saying this because we don't want to, we're afraid of the laboratory that we're losing business because we're not printing provisionals. That's not it. We have enough things to fill our funnels, but I really want you to be aware that of what you're getting and what you're going to need to be doing. So this is an actual scan that Tremaine provided me for a case that he designed. And what you want to ask for is that, well, I'll talk more about this, is you're gonna want to have the a scan of the provisional. This is the provisional on the model, patient model. This is, you see an integral view of it and an occlusive view of it. So the once the lab gets the file from you from the scanning, it's going to be somewhere based on the lab, could be anywhere from not probably much less than an hour, but 90 minutes, 2 hours is kind of a comfort zone because things happen. Uh, but they'll get you the scan in 2 hours. And then, okay, you've got that scan. Now, how long does it take you and your printer, et cetera, to do that? But just keep in mind, if the cutoff time, if the lab says, for us to get it to you, doctor, we need it by 1 p.m. within the time zone we're located. Maybe it's 11 a.m. in the time zone they're located. You're dealing with a laboratory in Florida and you're in California. You have a 3 hour time difference. You better have that worked out, dialed in, because you're going to be disappointing some people, yourself included, as well as your patients, when you're not able to do what you promised you were going to deliver for the patient. So again, prior to doing this, your first case, even if you're doing printing of, you're printing surgical guides, you're printing temporaries, great, you know how to print. It's a little different when you get into provisionals. You're using a different type of material. The materials have really advanced. If you have material, printing material that's you haven't bought, and I'm not talking about expiration date, I'm talking about technology date. In the last year, some of the advancements, some of the materials we were using 18 months ago or so, they worked, but they weren't quite, either the strength of it, the workability of it. Today, man, some of these materials are really great to work with. So that's a whole other thing to research out, talk to your laboratory. We're going to help you be successful in your practice. But my point here is this, that I want to share some tips and pearls with you about not before, but if you're going to do your own printing in-house. is to this. First off, before you have a real case, ask the lab to create a provisional design. Could be one they've already done, but then have them print the model and send you the model from a design that they have. And then so now you have a physical model at your office that you have the STL files, and now you're going to print, okay? And you're going to need to then you're going to print it, you're going to have to wash it, you're going to cure it, you're going to need to stain and glaze it. But what we're really wanting you to do here is to do the print, try it on, make sure you're getting that you're dialed in, so to speak, that your offsets are all dialed in on your between your software and your printer. The other thing is, how long does it take for you to do it in your practice? Um, you need to figure this out, because if you're thinking, oh, lab's cutoff time's 1 o'clock, I'll get it by 3 o'clock, that doesn't leave a whole lot of time for you to do this if your print time's 90 minutes or what, regardless. Just these are things for you to think about. Do this ahead of time. I think this is a great tip. Again, kudos to my buddy Tremaine about making this comment. To me, that made so much sense. Um, and it should be no problem for a lab to do that for you. Um, Again, you need to know what is your time for printing, the curing, the washing, the staining, glazing. Who's going to do it in your practice? Are you going to do it? Is that cost effective for you to do it? Yeah, etc. Then what is your surgical cutoff time to make the lab's time? So you can't, maybe don't start surgery at 8 o'clock. Maybe you need to start surgeries at 7 a.m. Well, you got to talk that through with your team as well to make sure they're okay coming in at 7 a.m. So again, they're just things that you need to be thinking about. A lot goes into this. And so you don't have to reinvent the wheel. There's been a lot of us out there that have already done it for you, so to speak. So we kind of talked about this. So just things to work out. Okay. And maybe for you, if you're going to do your own print in office, is just take the pressure off, let the patient go home, come in the next morning, and you have all the afternoon or evening or whatever to get that for the patient. So something else to think about. But once again, talk to the lab, talk to people. Okay, now I'm going to take you through a day of surgery on the fully guided and kind of what that all looks like. Those of you that maybe have done some cases with in sequence in the past, this is what you're probably going to get a review of. Very brief. I'm not going into much in depth and detail. We have a lot of this on our website if you want more information. So after your online meeting, then the lab goes to work and creates all the guides, etc. So everything's going to come packaged in a very organized. Everything's going to be labeled. And once again, these are all the items that you're going to be receiving. I'm not going to go too much into that. And you're going to see that in our full in sequence protocol, you do get 2 provisionals. And the reason for that, you want to, and ideally, you pick them both up on the same day. And the reason for that is it gives you one, it gives you a backup. But secondly, if something was to happen, they break one, you have a backup. But also when it comes to the restorative for the final, it's a modified way instead of going the conventional route to get to a final, save appointments, make it a more simple procedure. What's nice about this is not only do we tell you what multi-unit abutments are needed, height, angles, cuff heights, etc., but we'll pre-cut the coping, the temporary copings or cylinders to the right height, provide you blockout plugs, and they all come packaged in. So again, it does a lot of the work for you that you need to do chairside. You're going to get a lot of reports, a lot of information, bone density charts will help you know what each implant site, the bone density at the crest of the bone, at the apical of the bone, where the bone changes. Drilling sequence, basically, this is from the implant manufacturers. We don't dictate to you in any way, shape, or form of what protocol you should be following, but we're providing the form that we just copy from your implant manufacturer you say you're working with. Photographs of, we document your case and different procedures, different steps in the lab, etc. So this is a little video here I'll just show you. So teeth have been extracted, except we kept 2 for a tooth-supported monostrut. That plastic is referred to as a monostrut. Big flap, This particular case was required for a lot of bone reduction. They all don't need this much bone reduction. Um, but this plastic component, monostrut, is what's utilized to get that metal piece, which is called a bone foundation guide, which is it's a great name for it, bone foundation guide. It's the foundation of all these stackable guides of how they're going to go. And as you hear about stackable guides, many labs are providing them now. Implant manufacturers are some of them are doing their own as well. So you got to get that metal part in the right spot because everything's predicated on that being in the right spot. So that's just kind of showing you how this works. And then there would be here's an anchor pin. There's 3 horizontal anchor pins that we like to utilize a 1.5 drill, 20 millimeter long pin. That way we get bicortical stabilization, buccal plate to cortical plate. So that when you are, sometimes you're doing a little bit of force, this guide's not going to come, breaking through some of the softer bone. But I just wanted to kind of share that with you. Haven't seen that. Then with some of those guides we have, here you see it seated. Oh, sorry, I bumped my mouse. This is, there. So we have bone cut model. So we tell you based on the plans, there's so much bone is going to be reduced for the particular patient. You can see it's replicated here. So we know that that was in the right position. Now the bone reduction, you go from flat of the metal to the palatal side, flat of the metal. Some people may use, different burrs, whatever, but this is a nice baseball sized burr. Dr. Picos has a burr, I think, it's a great burr. They call it the Picos burr. It really gets in and gets after it. But here we are, you know exactly, about where to reduce, where the bone needs to be reduced and to what level and to what angle, anterior posteriorly anterior posteriorly angle to get the bone. Because you don't want to get the right bone in the anterior part of the alveolar ridge, but then on a wider ridge posteriorly, you didn't get enough. Could be a little awkward for the laboratory to try to make a good functional from a standpoint of hygienic prosthesis for the patient. So then now the surgical guide gets pinned in the same way that monostrut was. And then now you do your osteotomies. There's your mark that we talked about that on a regular surgical guide. So you have guided bone reduction and you have your guided surgery of the implant, guided placement of that timing and depth control, which is key. Then as far as guided prosthetics, so here so MUAs were put on. I did skip a slide where we have a template that you can put onto that helps you get the right position of the multi-unit abutment. Apologize for that. But here you see the temporary copings are all in place. A prefabricated tissue gasket protects the surgical site from any of the luting material. And then the provisional has a little arms on it that again gets pinned on, stacked on to that bone foundation guide. So you can now start to see the value and the importance of getting that metal or the bone foundation guide. Some companies make them out of plastic. We still do too. We do only usually do that for the sake of time. It takes longer to make a metal guide than a plastic one. So, but we like the metal. It's lower profile, stronger. But either way, just a little sidebar conversation with you there. So here you see the gaskets in place. The provisional we call long-term provisional. So we call that a LTP, long-term provisional. Get seated. That would then get pinned. As you see here, we are now using metal pins instead of little plastic ones. We have pre-drilled injection holes. You can see one right here. You like to inject from the buccal first. Watch it fill up. Take a little perio probe, stir that around. Make sure you're breaking the air bubbles. We have the blockout plugs in place. And then as you fill that hole up, you go to the next hole, inject the next hole, the next hole, the next hole. Hit it with a light cure, use dual cure. Like to use dual cure with these type of cases. So you hit it with the light to really set it, but dual cure is nice because light cure based on what unit you're using maybe doesn't penetrate deep enough in some of the areas, and nothing worse than you start removing a prosthesis and you get this stringy acrylic and your temporary coping stays there on the MUA. Oh man, that's no fun. So I like dual cure material for that purpose. And then now I'm going to take the little prosthetic screws out. And now that the copings are bonded to the luted to the bridge, you just remove these little pins that were holding it. And your conversion, with you will, if you will, is to cut off the little extension here, these arms, smooth them up, backfill these little voids here. Maybe you have to do a little filling here or there. I like to leave a little extra. I missed it because I was filming this and talking and forgot to add a little drop there and then wipe it with a Q-tip so you don't have to come back and do a little something there. And then that second, we would suggest if you're doing the full and sequence case with that second bridge, place the second set of copings. We send you two sets of copings and just repeat what I just showed you. It takes about 10 minutes, 8 to 10 minutes to pick up the second one. And what that's going to do for your restorative doctor is, and then if you are doing both the surgery and restorative, what that's going to do for whoever's restoring it, you're ready to deliver. I mean, you're ready. Implants are integrated. You're 4, 5, 6 months out, and you're ready to start the final. Then this second bridge can actually act as, all these kind of combined into one. And sometimes many of these are a separate appointment for that. We'll go, I'll go a little bit more into that when we get to the restorative. But that's the day of surgery. Okay. So I covered a lot on the day of surgery. We talked about freehand surgery. We talked about guided surgery. We talked about fully guided surgery. Then we talked about, on that surgery, where does photogrammetry fit in? What does it do for you? It's going to give you an exact, very precise, I hear numbers of accuracies in the micron, measured microns of 5 to 10 microns of accuracy. Um, the precision iOS, those scanners. If I hope I'm quoting these right. I'm hearing in the microns, maybe the 60 to 70, 80 microns accuracies. Still very accurate. Is that, so we learned or are hearing a lot about the different technologies. How are you going to incorporate the scanning in your day of surgery? There's be a lot of scans. It's just not 1 or 2 scans. Sometimes you're looking at about 5 scans on the day of surgery. Nothing wrong with that. Just don't want you to be surprised about it, but be aware of that. And if you're doing a patient that's not sedated, they're not able to open very wide. And some of these scanners, the camera itself, it's not a toothbrush. So those are things to think about. Patient selection. There's a lot. There's a lot to this, and just do your due diligence, and you'll be just fine. So let's get into the restorative part. All right. So now you did whatever you did. Patient's been in a provisional. Now we're ready to go to the finals. Are we going to do an analog conventional protocol? You're going to utilize this precision iOS technology, or did you do a fully guided, what I showed you with the sequence and how that's going to come about? So quickly, because this is going to be quickly, because I'm not going to spend much time on this because I don't know how many you are ever going to want. If you've done this, you probably don't want to have to do it again. If you haven't done it, go ahead and do it one time. That may be a one and done. But I'm not saying you need all these appointments, but you do need to have at least an impression appointment with an open tray impression, ideally. Does it need to be a custom tray? Not necessarily, but it's not a really bad idea. It's a good idea to do that. If the patient, we're talking about occlusal rims, then you need to do, verification jigs, metal try-in. So anyways, look, this served us well for about what, 20 years. Some of us have been doing these type of cases, but it's 2025 now. And let's look at some of our other options that we have here. So I'm going to just take 2 slides and kind of show you taking the fully guided, if you had that second long-term provisional, what you would do. So now, once again, this is the patient ready to start the final. Implants are integrated. So one of the things we need to do is we need to capture an accurate impression of the transition line. That has changed from the day of surgery. And some of the things, some of you have heard me before, watched me or been in my lectures, what have you. We talk about the transition line. What we have found doing, literally, I guess I can say thousands. I don't know if I want to say tens of thousands, but a lot of these cases the last 17 years now, 16 years, 17 years. Wow. Um, that I'm doing my math. It's crazy. Um, I'm not always good at math. That the transition line, meaning where the prosthesis meets the alveolar tissue, the ridge, that's the transition line. We found that for that not to show during patient laughing, talking, smiling, now you get some of them that had a high smile line, but for the majority of people, you put that transition line 3 millimeters above the highest smile line, the highest physical line they can go. So even those patients who give you the big ha ha horse laugh, you want to document that because we want to go 3 millimeters above that so you don't see the transition line. Now, that could mean this patient may not be a candidate for this type because you may have to reduce a lot of bone and you're into the nasal cavity or removing sinus and what have you. So it may not be feasible for that patient. Not every patient is a candidate for this just because their wallet is a candidate for it. So just because they want to do it and begging you to do it and flashing money in front of you to do it, they may not be a candidate for it. Sorry, got on my wagon again. So what you're seeing here is patient comes in, you would take a medium light body PVS, you syringe all the way around, capture a transition line, get a nice bead, palatally go around or lingually you go around and do the same thing. That's going to be your impression. Then you could take a bite register. Always get a new bite registration because sometimes things have changed over the few months and get a new opposing. So yes, we're kind of showing a little the my analog, but you don't need to do any of this. You can do all digital with this as well. So you don't have to do a physical impression. This could be a digital impression. You just scan, you scan the bridge in place, scan that gap. The key here, folks, when you're scanning tissue below or above, however you want to say that, the transition line, try to capture in your scans at least 5 millimeters. Make that kind of your golden rule to capture 5 millimeters on your scans of the tissue. That gives the lab, because what the lab is looking for also is try to make proper emergence profiles. So it's if you think about implant, crown, and bridge, the emergence profile of a crown, you have a deep sulcus that the lab would really love to get those impressions. We love those contoured healing abutments or your temporaries that have been contoured like a tooth, what have you, because we capture that emergence. We can see that emergence, and we can develop that crown to just nicely flow and blend into that. We can do the same thing with this full arch. This is what patients are judging you by when they hold. They're not just gonna go, hold the mirror out here like this and go, yeah, that looks really good. Thanks. They're gonna hold their mirror like this, and they're gonna do this, and another mirror here, and they're gonna do this with their lip. So, you know, we can really make these quite nice. All right, so that's your first appointment. You get those final records of the tissue, the adaptation, new bite. Always scan a new opposing as well. Maybe a tooth chipped off on their opposing, things like that. Maybe there's some mobility. If they did their upper, maybe their lower might need one too. Eventually, just can't maybe afford to do both. So before you go to a final, always make sure you get I was gonna say a fresh, I guess that's a way to say it, a fresh impression, be it a scan or a physical impression of the opposing. Uh, Really recommend try-ins, even though you could say, well, a patient was happy, let's just go to a final. It's your call, doctor. Of course, you're the, you're in control of that. But I got to tell you, sometimes it's really interesting when we do a try-in, and we can do either printed resin try-in or a wax try-in. What's nice is these printed try-ins will do what we refer to as I'll show you that coming up here, how we do it when we do the Simply iOS or the Precision iOS. I'll talk more about a resin prototype and how to do that in a couple of slides. I'll do that when you have a visual to look at here. So I know that our prosthodontist friends like to have wax try-ins because they can move the teeth around and enjoy doing that, and that's wonderful. That's great. So your second appointment could be a try-in. Third appointment, we deliver the final prosthesis. Some people may skip that, and it's a two appointment, and you're delivering the final. That's up to you. Again, work out that with your laboratory. All right, so now we're on restorative with your precision IOS. This is where I think that where you all are, most all of you are wanting to be and are going, striving for. And this is a very predictable protocol. Um, the bugs have been worked out on this protocol, and it's it's really cool. It just really amazes me. So we're at phase two, digital workflow. This I'm showing you is for the resin prototype try-in, and I strongly really recommend a try-in, and I'm going to show you why here. All right, so here's your first restorative appointment. Implants have been integrated. And here we are. Patient shows up. And this is my buddy Tim. And so we still want to we love still getting photos. We want to see the patients, get their eyes. We really like to see, close to the top of their head, not much more than maybe an inch outside their ears, a couple inches below their chin. Let's see some left and right profiles, retracted images. So photos are so nice for us to have. It also helps the technician to, feel like they're working on a person, but it helps to see more the shape of their face as well. And smile designs, we have so many options with smile designs and, shapes of teeth, etc. So this is, we don't get to see the patient, so this helps us a lot. So we really welcome these photos. And today, your iPhone's perfectly fine doing that. Snap some of those photos, easy to shoot those to us. All right, there's 5 required scans on the day of your first restorative appointment. All right, getting ready for the final. So patient comes in. We love those photos. Thank you very much for that. Now what we're going to do is you're going to scan the existing provisional in the mouth. So just go in and scan, and you want to capture as much as you can. Go back posteriorly as far as you can get. Again, capture about 5 millimeters of that of the velar. If you get down to the vestibule, I mean, we're not the vestibule, we don't need that, but get 5 millimeters of that alveolar tissue all the way around. Posteriorly, get back as far as you can. So that's a 360 scan. All right. So you got that scan. Now, very importantly, this is where people miss some things. Sometimes on a day of surgery, especially for our friends who've done things free-handed and not limited to only doing free-handed. The implant maybe didn't get exactly where you wanted it, or maybe for whatever reason, you didn't get the multi-unit in the exact rotational position. And the screw access hole didn't come out really ideally where you want it. Maybe it's coming out on the facial. Not a good situation. So it would be a time this would be the point to say, all right, we need to change out the multi-unit abutment. Maybe you had a straight abutment in the anterior, maybe a 17-degree, place a 17-degree MUA in and bring that anterior tooth so that could really help with the outcome of the case. For aesthetics, for strength, posteriorly, maybe you're getting out here on an embrasure, or maybe you're into, oops, sorry, my fingers got a little heavy here. Let me get my mouse back. Come on, buddy, there you are. Maybe this screw access hole is coming out on the lingual here. And from a patient's comfort perspective, how's that going to feel to their tongue? If the lab's not able to, blend in with their, on their design and bring some zirconia or some, nano ceramic or a denture tooth, whatever out here. So maybe my point is, this is the time. Implants are integrated. You're not going to hurt anything by unscrewing a multi-unit abutment. If the implant's moving, you want to know it now because that implant's is not integrated. If you're taking off an MUA that's torqued in at 30 newtons or 25 newtons, and you're untorquing that at the 35 newtons, and that implant is coming out, there's some other issues you need to be thinking about here. So, but now is the time to improve the outcome of this prosthesis. they expect this to last a lifetime in 2 days. So, and rightfully so. I mean, they deserve it to be very nice and functional. So, I know I'm expanding on this. It's a very important part, and I see it missed, and I see the disappointment with patients sometimes, and the doctor's uncomfortable when they're explaining to the patient why this caused, they did a composite plug, and to the degree they're able to match that, and light reflects differently from zirconia to a composite plug, and even from a denture tooth. So just things to keep in mind here, folks. So that was the scan of the working arch. Scan the opposing, okay? Scan the bite, and you're going to find, I'll just share this with you now. Now, I think they're going to start working these bugs out, but found many times that we've had to turn off the AI on these scanners. The AI sometimes doesn't want to give you as much information as the labs need. Um, it's thinking that if you put in like a bridge and it's only wants to do so much width, and you start going into the palette because you're trying to capture that, that reference screw, that fiducial marker, it'll show it. And then as soon as you click your save button or your enter button, it disappears. And it'll go time and time again, that'll happen. You may need to turn off the AI feature or maybe go into denture mode. I know one system we were working out was an older one, and we had to go to model mode to be able to capture the data. Do these things ahead of time. Don't do this on your first patient you're doing to learn these things, unless it's your, I was gonna say unless it's your wife or your husband, but that's probably not a good thing to do either. But just, do things ahead of time. All right, so there's three of your scans. Fourth scan. Now you've got you take the provisional off, and we want you to scan the tops of those multi-unit abutments. Boy, this patient needs a pat on the back. They did such a nice job with their home care. Isn't that nice? I mean, that's really nice, healthy tissue. And that's what you like to see. Um, Again, just capture as much tissue as you can there. And then the fifth scan is going to be of the provisional out of the mouth. And this you're scanning 360. Again, you want to dry it ahead of time. And uh, you get all of it. You capture all of that. Okay. And once again, as a reminder, some of these will not have uh, today, most of them are not getting metal copings if you're using the iOS the way I showed you from the day of surgery. So there's your five scans. So this, again, it's five scans, but they don't take that long. It probably like taking two PVS impressions is what it takes that time. But it's a lot easier for a patient to do this than sometimes those impressions. So uh-oh, what's happened? Did Jeff put the slides, repeating slides again? Yeah. This time Jeff didn't make a mistake. Now you're going to go back to again, the same system that you used the day of surgery. Um, and you're going to do pretty much the same thing that you did, except now the tissue's healed. And again, you're just going to repeat that process, and there's really not too much difference here of what you're going to do. So you do those, uh, you scan those, and then you're going to upload all that information to the laboratory. You're going to reseat the provisional the patient came with. So that's your first appointment. And so the patient leaves the way they came. And now we've got all this wonderful information. And so then the laboratory, be sure, yeah, we want to, update your RX is a good thing. Pardon me, a good thing to do. Um, Pardon me. Oh, make sure any of the screws the lab sends you, be sure and keep track of those and send them back to the laboratory so you don't get charged extra fees and et cetera. If you're sending some of these luted scan bodies together, make sure you pack them well. It's embarrassing sometimes opening these boxes and to see how some people are packing these things. Pack them with care. It's a very important. You don't have patients to have to come back. So That was your first appointment for working toward the final. But here we are, your second restorative appointment. Now we're going to try in this resin prototype. So remove the patient's existing, and you're going to seat the provisional. Now, this is going to be a monolithic printed one piece, like a PMMA, if you will. And the lab, you need to talk to the lab. If they're doing it for just a verification of the bite, let's say, or phonetics. In other words, the patient isn't going to walk out with this. You just want to validate that maybe some of the changes you asked the lab to do from the initial appointment after, from your first appointment, you asked to maybe to move a midline, made the teeth longer, change the shape, do something like that. Um, it'll be all solid white. And one of the things that the lab can do is they can paint some pink on it. And I'll talk about it on the slide coming up here, why that, where's the benefit with that. If you haven't heard of the Sheffield test, just go on YouTube, Google it, Sheffield test. This is a great way. We're doing these full arch. Well, you're doing a cross arch. You're getting cross arch stabilization with these prostheses. Um, Getting them into seat, which screw do you put in first? And if you tighten this one all the way and it kicked it up on that side, or you go here, how do I know if it's warped, if it's, is it as it has a passive fit? Well, the Sheffield test is a screw test for doing that. And I'm not going to go into how it's pretty straightforward to do it, but there is a protocol for doing it. So just Google that or YouTube, the Sheffield test. There's so much information on there. I just felt like I'm going to tell you about it. You scope it out, and you'll see what we're talking about here. So you just want to make sure that that fits well, and then you're going to go ahead and put the rest of the screws in, and then you're going to do your evaluation. How's the occlusion? Go with excursive movements, their F and S sounds. All the things that you're doing. This is your aesthetic evaluation, functional evaluation. All of it is happening right here and right now. Now, it's also nice to go ahead and take pictures of this for us. If it's a minor change that you want, if there's major change or something, yeah, photos help us talk about it. Put a Sharpie, mark some things up, draw on it, pencil it, do something. Uh, just give us more information if somehow we didn't get it on that second appointment. You're going to want to scan the bite with this provisional as well. So you've scan the bite. If you made occlusal adjustments, then rescan. You don't need to scan the provision. I mean, scan the try-in. We already have that. We have that file. If you went in and made an occlusal adjustments on it, you need to scan it. Or let's say you did adjustments on the opposing and you didn't want to adjust the upper for whatever reason. You want to adjust the opposing. Get a new scan of that opposing. Um, Once again, we just want to make sure that before we go to the final, that all the occlusion is worked out. You should not have to pick up a burr and articulating paper when you deliver the final. I mean, it's a good thing to do still, but ideally, if we're doing these things, we do them properly. Um, you know, you should have very little to no occlusal adjustments. And again, let us know if there's anything you want changed here. Now, let's say that patient, you get the resin prototype and you don't have that adaptation that you're looking for. And, old school would be we do a wash impression, do a wash impression, kind of like I was showing you with the in sequence provisional in place, injecting that. That's a way to do it. But as I mentioned, that you could scan ours, you scan that with your iOS scanner and not have to pick up any impression material. For sure, you can do the same thing here. So you would just scan the resin prototype in place. Again, do that 5 millimeters below or above that transition line. Remove the prototype scan those exposed MUAs. We got to make sure we're lining things up still properly here. Now, here's what's kind of cool. The patient, especially those who maybe you're really working on vertical. Maybe it's or aesthetically they're really challenged. I'm not talking about when I say aesthetics, I don't mean talking about the translucency, the reflection of it, because it's not going to happen here. It's a PMA, it's printed, right? It's chalky looking. I'm talking about the length of the teeth when they smile, but the lab, if you're going to, the patient can wear this. My point is the patient can wear this for about 1 to 2 weeks, not much more than 2 weeks, and do what we refer to as a test drive. They can go make sure that the things that we worked out previously, yeah, I like that. I don't have that lisp anymore, or my 50-51 sounds better. Yeah, all that's good. My excursive, I'm not banging anymore. You're happy, they're happy. So they can wear that, okay? So either they would leave with that, or you could just take that and remove it and then reseat the provisional they were wearing, and then you would return that prototype to the lab. If you had a new bite scan, upload that, photos, prescription. Now, I highlighted D, 9D, so check out 9D here. Let's say that everyone's happy. They don't need a, maybe they can do a test drive if they want to for whatever reason, but they're not going to make any changes. So you just realize that. You could just say to the lab, hey, go to final. We've got all the records. Instead of printing the PMMA, we could go ahead and fabricated a zirconia or a nanoceramic or something like that. So um, just some cool options that you have. Okay, so now we are talking about the delivery, our third appointment. So we're ready, patients excited, they're going to get their final. And what does this look like? You're going to remove the existing uh, provisional, or maybe that test drive they were wearing, the resin prototype, clean off the little MUAs, and you're going to use the Sheffield test. You're going to seat that final. And this is very important. Schedule the patient right after your delivery for at least a good half hour. Maybe, was that, I forget, is it 2 units, 3 units, whatever. I forget how the units work. Maybe they're 20 minutes to a unit. But patients been doing great home care. Oh, the tissues look great. That's fine. They're doing great. No, I don't mean like, no, no, they're not. It's not done yet. This now fits, is adapted to the tissue differently than their provisional they wore for 4, 5, 6 months, where that provisional, maybe they had access real easy to get a dental floss in or water pick in, or easy to clean. We've tightened things up because we don't want gaps when they lift their lip up and look at it. We want this to be really well adapted to the tissue. So you're going to have to probably your hygienists need to retrain or reteach them, so to speak, how to, and maybe they have to modify their home care protocol. Maybe they need something different to be able to do that, to get something in there to clean underneath this prosthesis. So that's very important for have them do this, because a lot of them still, after they spent all this money, went through this, they think, I'm done with you. See you, doc. And I'll see you in 3, 4, 5, 6, 10 years. I'll see you when something happens, is when I'm going to see you, when something hurts or something breaks. So it's important to take this and give them that time with your hygienist, and make sure your hygienist is up to speed on protocols for these. I should have put a slide up here, but I'm going to shout out a name, Susan Wingrove. Um, Wingrove. Susan Wingrove has written a couple of books on hygiene. Um, Phenomenal books. My email we'll get at the end here. She's phenomenal. She lectures all over the world on hygiene. She's one of those that does all the studies. She's a great resource to refer to her. She works with very top clinicians. They all come anyways, my whole point is there's a good information out there. Um, Reach out to me. I'll get you connected with her, and get her book for sure. All right. Your other option, though, folks, you could disregard all the stuff I've been talking about because you still could have fun on, and on that day of surgery, you could have done the conventional and, you could have had all this fun of taking immediate denture after your implants are placed, grinding holes in it, make your own rubber dam, put the copings in, cut the heights of the copings, and the fun's not done yet because then you get to cut the palate out and you get to cut the borders out and you get to backfill the integlo area to make it hygienic. And of course, you all have pumice wheels because you want to make a nice shine on this in your office, pumice and high shine. Uh, and then, then plug up those screw access holes and there you go. Now, I'm not saying this is wrong. It's what we've done for a long time. It's what we had. It was what was available. It's what we knew. It's what some of the technology had limitations. So we're now at a different point in our profession. And doing freehand, I'm not trying to make fun of anyone doing it. Some people may actually enjoy doing it. I hope I never have to do another one. I did one about 3 years ago to help out a doctor friend of mine, and she begged me to do it, and I just didn't want to. And I did it, and I remembered why I didn't like to do it. And 3 hours later, and I was still compromised end result after the whole conversion and thing. Now that's not the surgery. That was the conversion part. I'd like to think I'm usually pretty good at this. But either way, you got to have a trained technician to help you if you're going to do that. So that could be additional costs. More time ties up your chair, of course. More parts and pieces. You need to have backup things. And the converted dentures is not as strong as what we're able to print for you these days. If you see me anywhere, say hi to me. I would love to shake a hand. I'm here for
Thank
y'all.